Good afternoon, everybody. I would like to begin. I'll best introduce myself. My name is Councillor Zamir Ali, and I would like to begin by welcoming those members in the public and the press who have joined us today for this meeting for the joint Peterborough, Cambridgeshire and Peterborough Health and Wellbeing Board Integrated Partnership. We have several important issues to consider today at today's meeting. Before we begin the formal meeting, I have some housekeeping information that I would like to share with yourselves. Firstly, please be aware that this meeting is being live streamed to the Council's YouTube page, and that the recording of the meeting will be available on the Council website. Secondly, the Council allows filming and photography at its public meetings, so please feel free to take pictures and post them to social media during the meeting. Thirdly, can we please ask all the members to either silence your phones or put them on vibrate? And finally, if there is, my apologies, I'm losing my mind today. Finally, in terms of housekeeping notices, there is no fire alarm test scheduled for today. So if a fire alarm or sounds, please leave to the nearest marked fire exit. Proceed to directly down the bottom to the fire assembly point, Charles Swift Square, opposite the multi-storey car park. Item 1, apologies. Casey, can you please report the apologies for absences today?
Thank you, Chair. So we've had apologies from Jan Thomas, John Gregg, Jonathan Jelly, Louise Cranfer, Linda Thomas, Patrick Warren Higgs, Rob Bridge, Zoe Hutchinson, Carol Black and Piers Ricketts. Thank you.
Item 2 is approval of the minutes of the joint Cambridgeshire and Peterborough Health and Wellbeing Board Integrated Partnership meeting held on the 3rd of October 2025. The minutes can be found on pages 3 to 12. We are all being asked to approve the minutes on the joint Cambridgeshire and Peterborough Health and Wellbeing Board Integrated Partnership meeting held on the 3rd. Are accurate record. Are we agreed? Brilliant. Item 3. We are being asked to review the action log from the previous meeting. The log can be found on pages 13 and 14. Are we happy with that? Agreed? Item 4 is Cambridgeshire and Peterborough Neighbourhood Health Plan. The item can be found on pages 15 to 28 of the agenda. Pam Green, Director of Neighbourhood Health Places and Partnership, CPICB. Can you please introduce the reports?
Thank you, Councillor and Chairman. I'd like to introduce myself to the committee. I'm new here as the Partnerships Place Neighbourhood Director for the newly coming together Central East ICB, and I look after Cambridge and Peterborough as a representative. This paper I will take as read, but just to give a brief précis of the contents. and this committee with a wider audience has had a workshop meeting this morning, a progressive conversation about how we would come together to develop a neighbourhood plan. A neighbourhood plan is, whilst aligned to health strategy coming from central government, is cross-party and has great alignment to the wider determinants of health that affects all members of this committee and the public at large. It is a requirement of my organisation, working in partnership with statutory, voluntary sector and the public, to ensure that we develop a neighbourhood plan that reflects the needs of the population of Cambridge and Peterborough, addresses the health inequalities and starts to deliver on the basis of our place partnerships in north and south of the county, a neighbourhood health delivery plan and approach. Developing integrated neighbourhood teams that don't only serve health but social care requirements and engage the public and the voluntary sector in a novel way. I will take any questions on the paper, but just to outline the timeline, the plan needs to be developed by April of this year and a requisite delivery plan by September, ready for future commission in next year. I think it's fair to say that there's a heck of a lot of work that has gone on in Cambridge and Peterborough already, and we are not starting from a zero baseline. We are absolutely going to build on the real strength that's already here of organisations working together, but accelerating that to develop sustainability for services and channel the citizens' voice that has been engaged on already. Making the system more simple wherever we can. So I'm very happy to take questions on the paper, Mr. Chairman.
Thank you. Do the members of the board have any questions? And would you like to give? Hi, the mic, please. No? Just a button in the front? Raj, can you, yeah, there you go.
Yeah, I'm there. I'm so sorry. My name's Mike Knapson, for those who don't know me. I'm a GP by background, but I'm non-executive director of Cambridge and Peterborough Foundation Trust, a county-wide trust, so has an interest in both North and South Place. And my question was really, does this plan take account of the fact that neighbourhoods are changing? Because there are quite a lot of new towns or new villages being developed in the south of the county. I think Northstowe and Cambourne is expanding. And one of the things I've observed over my years in health care is that it's quite difficult and there's quite a lot of inertia in existing services. But when you're developing new communities around these towns, that might be an opportunity to develop services in a different way, because you're in a sense not quite starting from scratch, but you've got more freedom to act perhaps. And I just wondered if that was a consideration that you've taken into account.
So planning absolutely has to be a forward look, and it's, you know, through all of our work, population growth and developments, we're hand in glove obviously with local authorities around signing off those plans and being forewarned. We have to develop neighbourhoods that make sense for our population, and recognising that new towns don't always know necessarily what that means, but using the collective intelligence of organisations around the table, around town planning, bus routes, all of those sorts of things, green space, making sure that the access to physical activity resources are there, will be an intrinsic part of that asset-based approach to neighbourhood development. What I would say is that general practice is key to neighbourhood development and is a central tenet of that delivery. And I think you will know very well from your time in work in the community, actually the amount of activity that and kind of stories that come through general practice around access just not just to the practice, but practical things around bus routes and all of those things channel through that route. So we will have to, between us, really bring that voice of the community into our planning and design in a much more sensitive way to a 40 to 50,000 population demographic, rather than looking at scale. So it's got to work. It's got to work for the population.
Thank you. We've got Katie online, and then Sarah.
Hello everybody, and apologies for not being able to attend in person. My meetings have not allowed me to do that today, but in terms of the neighbourhood partnerships, I know how hard the changes have been for health colleagues, but for me it's really important that across Peterborough and surrounding areas, that in terms of deprivation, in terms of the family hubs, in terms of the Best Start Family Hubs programme that the government are currently rolling out, that partners continue to work collaboratively across the Safeguarding Partnership Board, and that we join up thinking in terms of ensuring that services are put into neighbourhoods that will directly impact neighbourhoods, because one neighbourhood is very different to another, and we have to all have continue to work with that collaborative partnership and ensure that communities are represented where there are differences. Thank you.
Sally?
Thank you. Yes, I'm very supportive of the paper and the direction of travel, and recognising that, we've come from a development discussion just now, but recognising that part of the ask in the paper is around the Health and Wellbeing Board signing off and having ownership of the neighbourhood health plan, which we will need to make sure we have enough time for in the subsequent meetings to review and sign off and be happy with that as a board. And I think that will be a standalone document that gets submitted, and it's, some writing on paper, but actually we need to have the conversation around how as a board do we really take ownership of that, and what's our role in that. Just reflecting on some of the conversations we've had just now, which I recognise aren't part of this paper, and we've only just had them, so they're just in my mind, but there's something around, this is the strategic oversight kind of conversation, and then how do we mobilise and deliver against that. But I think it would be helpful to reflect some of that as it comes through in the next stage to this board, in terms of what the plan looks like, and then how we articulate the role of the board and make sure we're all really signed up to that oversight of its delivery going forwards.
Would you like me to respond?
Yes.
So Sally, I think that's intrinsic in the success of it. Whilst I bring it because it's referenced in health policy, it is also part of local government policy. So it's, the delivery will test how closely we can work on that. And I would welcome the Health and Wellbeing Board to scrutinise the plan, sign it off with us, and hold the system to account, broadly, not just health on that perspective, but hold partners to account on that collective delivery. What will be established as a delivery committee will be a health and a neighbourhood health committee, a subcommittee of the ICB board at Cambridge and Peterborough level, to enable greater connection across the system of our mental health working groups, our integrated neighbourhood team delivery, our place delivery, urgent care, etc., so that we can bring to you a full view of the impact of that neighbourhood plan on the wider system, and enable that oversight.
Thank you. Can I bring in Liz?
Thank you, Chair. We did have a really good development session this morning, starting to think about this plan, and I'm fully supportive of it. there were a number of concerns expressed this morning about how much planning we're doing and how much doing we're doing. And I think it's really important that we reflect all the really good work that's already going on in the system and try and join it up through this plan and then monitor progress. So fully supportive. Thank you, Chair.
Thank you. May I ask? Yourself as well, because that would help us. Ah, sorry, I do. That's the button in the middle. Now you're.
Sorry, I was just saying I don't have a name tag today for some reason, but I'm Steve Barnett, Chairman of the North West Anglia NHS Foundation Trust.
Thank you.
We support this direction of travel very strongly. We recognise that the resolution of many of the current pressures that we feel in the acute sector lie in the effective development of integrated neighbourhood healthcare plans outside of hospital settings. But we also recognise, in terms of our responsibility as an anchor institution, that we have a responsibility to ensure that these neighbourhoods develop well and effectively, serve the needs of patients and our local citizens, but also I think address increasingly some of the various determinants that go into health and well-being in our local population. So, as I say, from our perspective, we want to strongly endorse this paper and the direction of travel.
Thank you.
Thank you, and thanks for that, Steve. I think drawing the alignment to your most recent clinical strategy that has been discussed with a wider audience in general practice through the collaborative group of working of our local GPs, in the north particularly, I think you can see that very much in your strategy, and as the support, as we audit the support to neighbourhoods, I think it will become clearer how we can mobilise that commitment you've just made to each neighbourhood. So thank you for your support.
Are there any more questions?
Yeah, thank you for the report, Pam. And I have just one question in regards to the LGR, the boundaries of the neighborhood. And is there any decision criteria in case they change based on what the government decides on those boundaries will be?
So we recognise there's huge change going on in strategic commissioning of the NHS with the ICB reorganisation, and we recognise that local government reform is also and reorganisation is also challenging. I think at this stage we have to work with the knowns, and neighbourhoods are very much recognised by the citizens that live within them and the arrangements of general practice currently. I think we will be able to be mobile enough to respond to local government reorganisation. I don't foresee that it will slow down anything. I think we will have to adapt, but I think the current plan is to get on with the neighbourhoods and then work with LGR as it comes along, and you know, keep us abreast of possible changes. But I hope that it will align with our current place arrangements and therefore you know, make things easier. But you know, I'm not in that position to make a prediction.
Thank you. Any more questions? Can we move to debate? Yeah. Is there any debate? No. Debate. Yeah. Colleagues, we are recommended to set the recommendations are set out on page 15 of the agenda pack. It is recommendation A and B. Are we agreed with the recommendation, or shall we move to vote? Agreed? Brilliant. See if we can make a note of that. Right. Item 4 is the Better Care Fund quarter two 25-26 report update. This item can be found on page 23 and 42 of the agenda pack. Can Carleen Townsend please introduce the report? Caroline, my apologies. Caroline. Thank you.
Sorry, Caroline isn't with us this afternoon. She's had to go home. She's not very well. So, Lisa Murray, Service Director for Adults Commissioning with Peterborough City Council, and
Sandra Pedley, Associate Delivery Partner at the ICB.
Thank you.
So this is, we're asking the Health and Wellbeing Board to approve retrospectively the submission of the Q2 Health and the Better Care Fund submission against the 3 metrics. I'm going to cover both Caroline, so Cambridgeshire County Council, and Peterborough City Council residential admissions. We're currently on track, reporting on track for both Cambridgeshire and Peterborough in terms of the target which was set in the Better Care Fund plan. I'm going to hand to Sandra for the health.
So the metrics which relate to health, emergency hospital admissions and the average discharge delays are not currently on track. There are particular challenges in certain specialties in one of the hospitals, which we're doing a bit of a deep dive into to see as to why we've got such long delays in some of these specialties. So we are working with the trusts to do that. And also on the emergency admissions, we're working with the urgent care services and trying to redirect them to services within the community to avoid hospital admissions.
In terms of planning, we just wanted to cover planning for next year's Better Care Fund submissions. We've referenced the neighbourhood plan. We don't yet have the guidance in relation to that, but that will be due, and I think that's something that we all embrace and would want to work with. I think the key for us is very often the timing is these approvals are retrospective, and we'd like to move much more to the anticipatory rather than the retrospective.
Thank you. Members, do you have any questions? No? That's absolutely fine. Colleagues, the recommendations are set out on page 29 of the agenda pack. Are we agreed? Sorry, Dean.
Apologies, I was a bit slow with my hand, apologies. I just had a question, if that's okay. I just wondered, from colleagues, if they could reflect on some of the changes that are coming down the track with BCF and what it might mean for this process, or do we not know that yet? I just wondered whether it might be worth just having a moment to have a think about that.
So we've had some discussions from forums nationally around the planning. We don't yet have the planning detail. We do know the neighbourhood plan forms a significant part of that, but from the Better Care Fund perspective, we haven't yet received the planning details. We're anticipating receipt of those. From my perspective, I welcome support from the Health and Wellbeing Board in the development of those.
Thank you. We'll try that again. That's absolutely fine. My colleagues, we are recommended to, the recommendations are set out on page 43. Are we agreed? Agreed? Brilliant. Agreed. Item 6, update on the Children and Young People's Mental Health Review and Redesign Programme. This item can be found on pages 73 to 86 on the agenda pack. Sorry? Is that item? Is it item 6? My apologies. Oh, have I missed one? Let's try that again. I do apologise. Item 5 is the health, life expectancy and preventable mortality. This item can be found on pages 43 to 72 of the agenda pack. Sally Cartwright, the Director of Cambridgeshire County Council Public Health. Can you please introduce the item?
Yes, I'm happy to introduce, and then I'll hand directly over to colleagues. So this item is the first in a series that we are intending to bring that gives an update on progress against the key outcome measures that we've set as part of our strategic priorities for Health and Wellbeing Board. So colleagues across Cambridgeshire and Peterborough have been working on this analysis and what it's showing, and some challenges around what we might want to think about doing differently based on what it's showing us. But I will hand over to Helen from Peterborough team, and then we've also got Sarah from the Cambridgeshire team who's online to talk to this item.
I did it. Thank you, Sally. So yes, I'm Helen Wyman. I'm an Intelligence Manager at Peterborough City Council here, and I'm joined online by Sarah Dugan, who is a Consultant in Public Health at Cambridgeshire County Council. And as Sally said, we're going to give you an update on our overarching goals for the health and wellbeing strategy. The aim is to bring one of these back to each board meeting. So this one is the overarching goals for the health and wellbeing strategy is to increase the number of years people spend in good health, to reduce inequalities in preventable deaths before the age of 75, so mainly looking at deaths that could be avoided through effective public health and primary prevention interventions. And then the third one, which is achieve better outcomes for our children, we'll be bringing back that one to the next board meeting as part of our update on priority 1, looking at good level of development and children and young people not in education, employment or training. So, quick look at healthy life expectancy. In Cambridgeshire, healthy life expectancy is 62 years old, and in Peterborough it's 55 years, so a difference of 7 years. But as we'll have a look in the next slide, there's a wide variation across Cambridgeshire itself. As you can see, this chart here shows the trend in healthy life expectancy over the last 10 years. Anything red is significantly worse than England, anything green better, and orange the same, yellow the same. And as you can see here, England is going down for healthy life expectancy, but Cambridgeshire and Peterborough are going at a steeper rate. So Cambridgeshire is the ones along the top and Peterborough are the ones along the bottom. There's a sharp decline in Peterborough. So that's one difference to the national picture, but the other one is for the first time locally, Cambridgeshire and Peterborough have higher health life expectancy in men than women. Very slight difference, but it's the first time that men have been higher than women. And because healthy life expectancy is the same in men and women, and generally women live longer, women are living longer in poor health. So women have a significantly high rate of poor health. Poor health is also related to deprivation, as you'd expect. So, and this is the same for disability, but the correlation to deprivation isn't so strong. So, improving poor health would have the biggest impact on healthy life expectancy. Healthy life expectancy is calculated using mortality rates and self-reported health self-reported health. So if we can improve self-reported health, that will have the biggest impact on our healthy life expectancy. And the main driver of poor health from national literature and evidence is musculoskeletal conditions. So if we can improve those, we improve poor health and we improve our healthy life expectancy. From data that we've got on work well, so unemployment and mental health conditions are coming through too as reasons for poor health. So as I said at the beginning, you might be able to see those, this is the healthy life expectancy by men on the left and women on the right across Cambridgeshire and Peterborough. The darker the area, the lower the healthy life expectancy. So we have in middle of Peterborough, in our more urban and more deprived areas, is the lowest life expectancy. In Fenland, Wisbech, but for women also in Chatteris and March. But also, as I said, there's a disparity across Cambridgeshire. So in the middle of Huntingdon, the Oxmoor has one of the lowest healthy life expectancies for both men and women, and as King's Hedges in Cambridge is the same. And between our most deprived and our least deprived, there's a 14-year gap in healthy life expectancy. So the goal to increase the number of years people spend in good health is currently not on target. Then to have a quick look at preventable mortality. Oh, I've gone the wrong way. This is a very busy chart, which you're not going to be able to see. But this shows, so that each dot responds to a time period. So these are the last 3 time periods for each of these diseases along the left-hand side. And colour coding the same. If preventable mortality is higher than England, it's red. If it's green, it's lower than England. And if it's yellow, the same. But also on here, we've got trends. So what's the trend looking like in these areas? And as you can see, both Fenland and Peterborough are the only areas that have high rates of preventable mortality. In Fenland, it's for cancer preventable mortality and respiratory disease, and in Peterborough, it's cancer, cardiovascular disease, and liver disease. But what this is also showing that maybe the rates in other areas are good or similar to England, but actually the trend's going in the wrong direction. So if you look at respiratory disease in Cambridge, it was better than England. The rates are going in the wrong direction, and so this is sort of like a warning alert sort of chart, I guess, about things that we ought to be keeping an eye on. And again, similar to the healthy life expectancy, the areas that have the high preventable mortality rates are King's Hedges, Wisbech, Oxmoor, and half of our areas in Peterborough, again around the centralised, more urban, more deprived areas of Peterborough. What isn't shown on here is that Peterborough has a high preventable mortality rate for cardiovascular disease in males and for cancer in females, so a difference in genders and by disease areas, and Fenland is respiratory deaths in females. We also looked at premature mortality, so deaths that happen before the age of 75 years, and as we all know, I guess, much higher in the more deprived areas for all causes, cancer, cardiovascular disease and respiratory disease for both men and women, and higher in men than women. So poor health higher in women and mortality higher in men. For example, in our most deprived areas across Cambridgeshire and Peterborough, cardiovascular disease in men is 2.5 times the death rates of women living in the same areas. So overall, so this gives a picture of by geography, by sexes, and things. And so inequalities in preventable deaths before the age of 75 are not reducing. So that's both of our goals that we're not on target for. I'm now handing over to Sarah, who will take you through the recommendations.
Thank you, Helen. So there's more explanation in the paper, but the recommendations are for the Health and Wellbeing Board to consider whether there is sufficient focus on musculoskeletal conditions and mental health, and including access to high quality services in the most deprived areas, as these are the conditions that will be driving poor health and healthy life expectancy, and unemployment as well, which is obviously one of the goals of the Health and Wellbeing Board. We also think there needs to be a better understanding of potential unwarranted variation in primary care. Oh, sorry. So this is where we understand if there are differences between what is happening in different practices or for different populations, which might signal that there could be improvements or different approaches to tackling some long-term conditions such as cancer and respiratory disease within those communities. And again, we would advocate that we focus on the most deprived communities for this. And it has, there is evidence that shows consistent application of NICE guidance, which is the best practice guidance for the NHS, in clinical practice can result in better outcomes in areas of deprivation. Our third recommendation is all around the development of the neighbourhood health plans. which are obviously a big opportunity for us to have a structured focus on some of the short-term improvements in healthy life expectancy and preventable mortality. And just to add, and it is in the background of the paper, that if we do want to make the changes to healthy life expectancy and preventable mortality within the lifetime of the Health and Wellbeing Board strategy, we are looking at short-term changes. So we would look, there needs to be consideration in our view on the local patterns of deprivation and the appropriate approaches to those. Those patterns are very different across Cambridgeshire and Peterborough. In some areas we have a large number of communities that are in the more deprived quintiles, where there could be a more universal approach. In other areas like Cambridge City, a more targeted approach might be more successful. And then in some of our rural communities in East and South Cambridgeshire, there are still quite large numbers of people living in poverty and who'd be impacted by poor health. It's just much more dispersed. So there needs to be a very hyper-local approach potentially in those areas. We also, as we said before, think the neighbourhood health plans need to consider whether there are opportunities to improve musculoskeletal health and mental health in working age adults. And that does dovetail with all the work on unemployment and getting people back to work, such as the Work Well programme that's already ongoing. We think there needs to be, and I think Val's going to be talking about some of this later, but the neighbourhood health plans need to include the system-wide approaches to tobacco control and obesity, which will be the main underlying risk factors driving some of these trends that we're seeing in preventable deaths. And again, they are more prevalent in the most deprived communities as well. And finally, it is looking again at this unwarranted variation in both the early identification, treatment and management of long-term conditions such as heart disease and cancer within high preventable deaths in those communities where we are seeing higher levels of preventable deaths. And as Helen said, where we're getting indications that the trend is going in the wrong direction. Thank you.
Thank you. Are there any questions? Steve?
Me? Okay, thank you. So it's obviously disappointing that over the period within which the ICB had agreed these two priorities, that performance in some of those deprived areas has actually worsened. I guess we could have known that in those deprived areas there was going to be more pressure on things like mortality and associated factors. So I guess I'm asking the question of, if we agree to further initiatives going into these areas, what level of confidence can we have that these are going to have the necessary impact which previous measures don't appear to have had?
That's a very good question, and I would echo the same thing because it's a fair. What confidence would we have? Sarah, if you.
So without knowing everything that's gone in the past, it does look like our healthy life expectancy is declining at a sharper rate than other areas, or certainly than the national average and other areas of the country. So I think that signals that there are opportunities for us to do things better, or at least explore and consider whether we are doing it as well as we could be, because we are declining at a sharper rate, and appreciating that the national average is declining, and a lot of that is probably linked with poverty and cost of living. But if we are seeing a sharper decline, I think we need to consider whether we have done everything we can do. I also think, as I said, there is good evidence from other areas that you can outperform basically your level of deprivation by getting some of the basics And I mean, in terms of clinical practice and other things, if you get those basics right, you can do better than the levels of deprivation would suggest you should do. So I think there is evidence from elsewhere. I think there should be consideration of why we look like we are doing less well than other areas on this.
No worries. Sally wants to answer. No, Mike.
Thank you. Yeah, thank you. It is disappointing, but I endorse the approach. And my question was, what's new that's going to make a difference? And I would say this, but from a CPFT point of view, and as a GP, quite a lot of the cancer and CVD targets are driven by poor mental health. And
Can I ask all members, this is a public meeting, so acronym-wise, if you can give the full name of...
Oh, yes.
Please, if you, like I said, that's one of the criticisms that we've had, that a lot of people don't understand. There's so many acronyms.
Forgive me,
Thank you.
Chair. So my name is Mike Napton, is that what you're...
Sorry? CPFT.
Oh, I'm the Cambridge and Peterborough Foundation Trust. Forgive me, I do apologise. Yes, so it's the specialist mental health and community health provider across Cambridge and Peterborough. And I think the point I was making was linked to, so why are we not achieving these targets? And the question is, what are we doing differently? So neighbourhoods seems to be an approach which might make a difference, and the focus on mental health, I think, is an important one, and how that relates to the way in which we manage serious enduring mental health illness, which drives that. You know, I'm told that there's a 20-year difference in terms of someone who's got schizophrenia or psychosis. But these people also are drivers of use of primary and secondary care services. And it's complex. And the other link I would make, not only to neighbourhoods, but is to what we're going to see in a moment, which is the children's mental health strategy. Because people's mental health in adults is, to some extent, determined by what they experience and the traumas that some children experiencing. And of course we know that for ADHD and autism, the waiting lists for those services are long. Children in care have problems. So I think I'm trying to pull out what's new, which might make a difference to the, and those are some of the things that I observe. But thank you.
Thank you. Would you like to answer it, Sally, or?
Thank you. So I was just going to make a point that's, I guess, related to both the previous points, actually. But I just, first of all, want to say thank you for the piece of work, because I think there's a lot of analysis in here that's really helpful, and it's timely because of the neighbourhood health plans and because of the way in which we're coming together now on some of this and all of the changes that are afoot, that it helps us maintain some focus on what we need to be doing differently. And I think the work of the neighbourhood health plans that is coming down the track, and the neighbourhood health teams, and how we think about where we need to focus, is really helpful to have this to base some of that on. So some of the more short-term things that we could be doing that have been outlined in the paper, such as looking at unwarranted variation and musculoskeletal, we can really use this as a impetus to do that better now and make a difference there. And some really positive work that will be coming down the track around some of that, I think. So I think it's really helpful to set the scene of what we need to do differently and what we need to make sure that at a neighbourhood level we're taking forward based on this to actually make a difference. But recognising, to Mike's point, that these are complex issues. There's not one driver. There's causes of this and there's causes of those reasons. And people are within neighbourhoods and families and complex settings. So the reasons for this are complex, but there are things that we can do about it, and we've got some core levers that can help us, I think.
Thank you. Raj?
Yeah, thank you. And I think I would echo Sally's point that the data just tells
Raj, may I ask you to just bring the mic forward so it's a bit closer?
The data just tells us gives us the answer to Liz's question about are we being effective as a board. I think we set these targets a while ago, and we have seen that we are not only achieving but actually going in the wrong direction. And Liz made that point this morning. And what are we going to do differently as a board moving forward to make sure that we're so for one, are we going to tackle some of those musculoskeletal mental health problems within those areas, and are we going to shift resources not just from hospital to community but also within the neighborhoods that need them the most?
Thank you. Is anyone else? Yourself? My apologies. Liz?
Thank you, Chair. So I'm really pleased to see the data, because it has felt like we've been currently working to do things and we haven't known whether we've done them or not. So, you know, knowing whether we've done something or not is progress. I'm not clear what we mean in some of these recommendations in terms of who's doing what. So I don't know who's responsible for unwarranted variation in primary care and whether anybody actually has any control over that. But it would be good to, I mean, not necessarily for now, but to firm up the recommendations so that we know who is responsible for doing these things, because otherwise there's, you know, potential that everybody will think somebody else is doing it, and you know, we clearly need to take some fairly kind of radical and direct action quite quickly. Thank you.
Thank you, Liz. Can I bring in Sally from that?
Sorry, I was just going to come in on that point quickly. So on the unwarranted variation, just as an example, I think it's a really good challenge that we do need to be clear who's doing what on it. I think the first point of that is getting the data to GP practices on that, which I've had a really positive conversation with Pam outside of this meeting that we're nearly there with being able to do that, which is great. So I think that's task one, and then the conversation around facilitating that with the GP practices to say, look, this is where how it's looking, how can we do things differently? So I think there's a real public health team role in that as well. So I think the challenge is absolutely right. Let's not just put the recommendations up and then think, yes, that's what we all signed up to, but actually not knowing who's going to take it forward is really good. So I think we need to work that through outside of the meeting.
Pam.
So thank you very much, Pam Green. I am from the ICB, and we are the responsible Commissioner of General Practice. So that really lies with me and the team around unwarranted variation. But I would say that this is multifactorial and it's multi-partner. So disease doesn't commence in primary care. It may be detected, but it is the wider determinants of health that this board is accountable for working with as a partnership to mitigate. And I think what the neighbourhood plan gives us the opportunity to do is to drill down to the populations that experience the widest health inequalities, and for us to focus our efforts, as you said, Raj. And we must ensure that where appropriate to neighbourhood, that is reflected in the neighbourhood plan as a shared plan, as we talked about in the first item of this meeting. I'm a physiotherapist by profession, so I know musculoskeletal does not, is not simple, even though it's to do with bones and muscles. It's not just the preserve of health. It is about working environment, it's about accident, it's injury, it's about repetitive strain, it's about all sorts of things that predominate in people's lives that generate musculoskeletal injury and illness. Now we are going to use the data here, working with the public health team, to derive that neighbourhood plan as well as our strategic commissioning approach. And as a strategic commissioner, we must absolutely be driven by that data and have the collective outcomes and responsibility defined. So you won't be surprised, because we're all working from the same data set, that musculoskeletal is going to be, of course, a priority of the organisation, because it isn't good enough to see that we are having the health inequalities and life expectancy for our population deteriorating in that way. So, you know, we must do some urgent and radical interventions, I think, as you suggested, Liz. So I think it forms part of the ongoing narrative and the work of this group.
Thank you. Are there any other questions? Would you like to move to debate? Oh, my apologies. Mr. Navarro.
Thank you, Chair. Luis Navarro, co-chair of the board and county councillor for Cambridgeshire County Council. I welcome also the report. I think the data is very good, and I know that we are always evidence-led in the approaches and the decisions that we take, and that's the only way it should be. But the data is, and the trend is very clear. And although I welcome the recommendations that we are being put forward here, what we expressed before in the 2 hours that we met before is that we need, yes, again, I repeat what Pam just said, urgent and radical approaches. If this doesn't trigger us, if the life expectancy of our population doesn't trigger us to do something differently, what is? So with that evidence, with that data, I encourage you to open up to other ways of implementing services, and I'll be very directive to make those services tackle the origin of the problems. No palliate problems when they already exist. I am sure that obesity, smoking, musculoskeletal problems have an origin, and it's that origin that we need to identify with the data in hand and tackle.
Thank you. Is there any debate? Colleagues, can we recommend, colleagues, recommendations set out on page 43 of the agenda pack. Are we agreed? Agreed? Thank you. I'll get to the correct one this time around. Item 6, update briefing on the Children's and Young People's Mental Health Review and Redesign Programme. This item can be found on pages 73 to 86 of the agenda pack. Kathy, from the head of Children and Young People's Mental Health Commission and Transformation, NHS, Cambridgeshire. It's a really long title. Cambridgeshire and Peterborough. Can you introduce the report, please?
Sorry, just checking the technicality there. Yeah, welcome. So thank you to the board for inviting us back here today. So I've come to present the paper around the update to the Children and Young People's Mental Health redesign and review work that's been occurring across Cambridgeshire and Peterborough. So the paper is an update on a paper that was brought in March 2025 to talk about the work of the Joint Strategic Needs Assessment for Children and Young People and the Mental Health Needs Assessment that had a chapter around children's mental health. And at that point, as well as bringing together the outputs of those pieces of work, the Integrated Care Board had its operational plan of 25-26, which identified children and young people's mental health as an area of needing focus and priority. From that piece of work, we brought together a programme to review the current provision of mental health services across Cambridgeshire and Peterborough for children and young people, and to commence a piece of work to think about how do we redesign that. And this paper is about the current position. Just be mindful, just to point to the board about there's several challenges that have been occurring during this period of time of this piece of work, notably the national reorganisation of integrated care systems, the ongoing constraints in finance that we're experiencing across health and care, and also how these are impacting on our communities. We started the redesign work in June 2025, and we've started to look at the information that was already available. There's been a lot of work nationally and locally over the last few years around looking at children's mental health. We felt it was really important to actually synthesise that information rather than start afresh and look at what we'd already knew and what information was available. So that's been a large piece of the work. So the report talks through some of that, and also in addition to that, the Integrated Care Board commissioned an organisation called PPL, which stands for Private Public Limited, which is a social enterprise, and they've come in to help us understand some of the provision from a baseline level of our providers, predominantly Cambridgeshire Community Services, who provide our community services and our mental health support teams in schools, and Cambridge and Peterborough Foundation Trust, who provide a number of our specialist mental health services for children and young people. So the PPL work has overtaken a baseline review to look at information, and that has pulled together a lot. When this paper was written, and still at this point, we aren't able to provide detail of that, because although the report is now final, there still is a lot of rigour going around the data and the information held within that report. The initial plan was the report was going to be finished around October, November, but because of the scale of the information that we had to pull together, it took longer than anticipated. So that's why this paper is an update paper rather than an output of the final recommendations. The paper talks through the process by which we did around the redesign. So I say we looked at existing information, and we've taken an approach to use a key line of inquiry and do a really robust analysis around the information of what we were looking through to look at a whole system-wide approach. We've also done stakeholder engagement to sort of validate that information to make sure we're not missing any key areas and key thinking around that. So that was held a workshop in the end of November, and we're currently pulling all that information together to look at what it is telling us and where we may need to think about our priorities. At this point is bring out a number of, say, high-level areas, but what this report and what the work to date is focused on is about the current situation. There is further work that needs to do about how we move from our current state into the future, and therefore that it's more been focused on the review element rather than the redesign. I think where we've experienced a huge amount of information to look through, and as I'm sure the board can appreciate, the complexity around delivery around children and young people's mental health means we need to really robustly think about how we support that and how we do that redesign. So as in the report, we talk about next steps. So we're not talking about recommendations, it's more as an information sharing, so it's around next steps. So we're set out the programme, we want to continue engagement with our local system, and as I say, there's still further sort of analysis and validation around the information that we've gathered to date that we need to go through to make sure it is the right information and it's fit for purpose. We also very much mindful around the neighbourhood work, and I understand there was further work happened this morning around that, and thinking about where do we, in the redesign phase, where does some of the work need to sit in terms of, does that sit at neighbourhood or does that sit at a sort of a strategic level? So that's a part of the work as well. So I say it's about, we have completed the piece of work to gather all the information, but there's still analysis that needs to occur, and I think the emphasis is to say to the board that we really need to think about how we move from utilising that information to think about how we plan what that needs to look like and what changes may need to come into place to meet the needs of our changing population around children's young people's mental health.
Thank you. Members, do we have any questions? Lewis?
Thank you very much for the report. Just a question regarding the expectation of the dates. When would the report be available? And second, when would you think that you'll be able to anticipate commissioning and the model, the service model changes, and how will neighborhood plans host multi-agency CYP teams? So yes, an expectation of dates that you're working towards?
So I think in terms of the sort of bringing together the review piece, the PPL work and the key lines of inquiry work, we're aiming to have that sort of pulled together by the end of March, at the end of this financial year. there is further work that needs to be done, and we need to identify who in the system will be leading that piece of work around what the next steps. So at the moment we haven't got that defined timeline.
Thank you. Mike?
Well, yeah, so firstly, thank you very much for doing this work, because obviously we're heavily engaged with the work that you're doing, the PPL review, and we're looking forward to see what the recommendations are. And I agree with the second point, which is about the complexity of all of this. And I've been struck, having been at Cambridgeshire and Peterborough Foundation Trust for just 18 months, having worked as a GP, the levels at which this works. So you've got the high volume of children who are waiting for ADHD and autism assessments. But then you've got, I've been really struck by the acuity and severity of some very traumatized children who have our Tier 4 services, and these are sometimes get forgotten because they're missed, and yet so the forensic mental health services for adolescents who are engaged with the judicial system, for instance, so there's that, and then there's the Learning Disability Partnership, which I gather is being reviewed in terms of its structure. So there's quite a lot going on. So I perhaps, why am I saying that? For information, really, just to put this in the context of what I see is going on for children with mental health. But coming back to the point I made earlier, getting this right will affect people's mental health when they grow up, and that will in turn affect our population health metrics. So these things are linked up. Thank you.
I'd just like to add thank you for the report. It is very much appreciated. It is ever-changing outlook out there as well. And yeah. Would you, sorry, my apologies. Sally, first.
Thank you. I suppose just building on that point, it's the challenge, isn't it, around all of those things that are interrelated and connected to this, and then all of the change that is afoot and coming down the track is around how do we maintain the forward momentum on it and the actions going forwards. So I guess it's a challenge to us as leaders and as a system to think about that. How do we maintain it going forward? And I don't know if people want to share any thoughts on that.
Thank you. Paul?
It's a separate point, but again, there's always a risk of repeating and building upon other colleagues' thoughts. Sorry, Paul Rogerson from Cambridgeshire Police. I just want to endorse probably the same comments of the importance of this work and the crossing themes around missing people, escalating crisis, school-based crisis, the waiting list, how that affects criminal justice outcomes, entrance into the criminal justice system. So again, really, really keen to see the recommendations and offer across, I think, the importance from not only a constabulary point of view, but from the community safety part of the network, which isn't necessarily represented here, and to reach out and offer the support and the involvement within this report as you build it. Because just with as with the GP service, the cross-cutting themes are detrimental to other areas of public service where we each are stepping into to support those young people, but inevitably with waiting lists and diagnosis taking longer and longer, the wrong service is stepping in, particularly as we reach the end of the right care, right person mental health piece of work. There's a risk that actually unseen from that work is we're doing exactly the opposite because we don't understand. But so as such, I look forward to reading the recommendations. Thank you.
Thank you. Pam?
Yeah, so I'm not going to suggest that the neighbourhood committee and neighbourhood work is the answer to everything. So it isn't a trend for that, because we have to be clear that we've got to have a manageable workload. But this is clearly a very important part of commission services, and a report that was initiated by the ICB with partners. And we can't have recommendations that don't go anywhere. I mean, that's a fundamental issue, isn't it? So whilst the ICB is reforming itself and getting its governance arranged through the nationally mandated change to its infrastructure and becoming a strategic commissioner as opposed to, totally doing the redesign, that it's intrinsic that this recommendation isn't lost, and that comes back into our organisation, to our strategic commissioning function, and then where appropriate will be supported by neighbourhood delivery and the neighbourhood delivery teams, as we've discussed already today. So I think it must come to its conclusion. The recommendations validated must be acted on, and the services need to be delivered against a set of strategic commissioning criteria. And that is intrinsic on the role of the ICB as well as the delivery partners within our system. So we can take it that this won't be lost in transition is what I'm suggesting.
Thank you. Would members like to move to debate? Okay. The recommendations are set out on page 73 on the agenda pack, A to C. Are we happy to agree? Agreed? Agreed. Item 7 is Cambridgeshire and Peterborough Tobacco Control Alliance. This item can be found on pages 87 to 116 on the agenda pack. Val Thomas, Consultant in Public Health, Cambridgeshire County Council. Can you please introduce the reports?
I'd like to put my microphone on as well. So I'd like to introduce John.
Hi, good afternoon. Jonathan Bartram, one of the Programme Directors within our Strategic Commissioning Unit in Cambridgeshire and Peterborough Integrated Care Board.
And good afternoon. My name is Damilola Akishulire, Consultant in Public Health for Peterborough City Council.
Right, well, you sort of moderate what you're going to say when you listen to the conversations that preceded this, and I think I need to preface this and the obesity one saying that I think both of them are talking about system-wide, and it's articulated in the recommendations in the tobacco strategy. It's actually how we then translate that into neighbourhood level as well, at that local level. So I think that's the theme, even though I think we're talking about broad strategies. Starting off with the tobacco strategy, and I think probably we've struggled with the name because with the emergence of vaping on the scene, it kind of, what can you call it? Because it does have an impact on the use of tobacco. So, and we were challenged at County Council, councillors challenged us on the name of that, and I think it was a fair challenge. So I think we have to rename it at some stage. But basically, I think we've seen in the past 50 years, smoking has just changed dramatically. But, however, we still get, huge numbers of preventable premature mortality. We get huge numbers of people being admitted to hospital because of hospital-related conditions, and similarly, huge numbers of people who present in GP practices. And the other, perhaps interesting, more aspect of this, particularly in the context of the earlier discussion around the outcomes and the profiles of our communities, is that there are huge disparities in smoking rates. So we might have seen a huge drop in smoking rates, but among certain groups we have, for instance, people with mental health condition rates are anything from 40 to 60%, homeless up to 80%, manual and routine, certain groups where we look as though we're going to meet that national ambition of a 5% smoking rate by 2030, but it's very unlikely that we will get there with some of these groups. And I think this is what underpins the whole of this strategy. And also, there's also been the policy and legislation changes, which actually brings new context to it as well, and has refocused attention on smoking, and also through that lens of looking at where are the areas we really need to focus on. Historically, across Cambridgeshire and Peterborough, I think we have a track record of working together to address the issue of smoking and now vaping. And the Alliance has been working quite a lot in recent years, particularly in the context of the new legislation, at reformulating its direction and what we need to focus on. And consequently, in June last year, we had a summit and identified the 8 strategic ambitions. And I think we share them across Cambridgeshire and Peterborough. And we also think that going forward, as we have this change in the organisational landscape, those ambitions will remain unchanged. The delivery will change, and that's why we have 2 delivery plans. The other important consideration is we've also, as well as the legislation and policy changes, we've also had the NHS Treating Tobacco Dependency Initiative, which has brought along the whole clinical dimension and the role that the clinical pathways play in this issue. A lot of people who continue to smoke present in hospital with respiratory conditions, which again was highlighted in the previous presentation. So it's kind of a wicked mix. And I think there's sort of, for me, there are a few areas in the strategic, few themes in the strategic ambition. There's something about getting to those groups where the rates remain high. There's something about, have we got our clinical pathways aligned to support, and do they offer support? And thirdly, there's the issue around illegal tobacco and vapes. But I think John is going to talk to a treating tobacco dependency programme as well. So the recommendations to the board is that they agree the strategic ambitions, commit to supporting the delivery plans through their respective organisations, embedding the strategic ambitions and delivery plans into a North and South Place Partnership neighbourhood health plans, and importantly, review the progress. Otherwise, we'd be coming here and say, here's a strategy, and we need to have that accountability and the governance to ensure that this continues to be taken forward, because it affects all parts of the system. So I'm going to, Damilola, do you want to say anything from the Peterborough perspective?
Thanks, Val. So it's just to state that we have developed a delivery plan that is bespoke to Peterborough City Council, because we acknowledge that the demographic profile in Peterborough is slightly different from Cambridgeshire. And so this presentation today is to seek your endorsement of the strategy and the delivery plan. Thank you.
I'm going to hand over to John now to hear about the NHS Treating Tobacco Dependency programme.
Thank you, Val, and thank you, Board, for the invite. So, yeah, I'm here just to give a bit of an overview as to what has been commissioned historically by Cambridge and Peterborough Integrated Care Board through some of the central funding we've had from NHS England as part of the long-term prevention programme funding that's been offered since 2021. So since that funding has become available to the ICB, we have commissioned treating dependency pathways in all of our acute providers, our inpatient acute providers, and mental health, as well as our maternity services. Since full establishment of those pathways in 2023, we've seen an additional 8,016 people identified as smokers, resulting in 3,500 of those setting an initial quit date, with 1,500 people going on to stop smoking. The impact that these additional measures have had has seen approximately 210 lives saved per year, with an estimated 5.5 bed spaces created per day based on 1 year readmission rates or reductions in readmissions. Just to flag, one of the highlights of this programme has been obviously the impact on the services through an NHS impact perspective, but also the integration of these pathways into other community-based services. So the full integration of discharge into community-based stop smoking provisions. Cambridge and Peterborough is one of only 2 ICB areas that have full established pathways in the east of England, showing that great integrated working between the NHS, local authority and other services. So again, it's a recommendation, I think, under 4 for the improvement of pathways and building on the Treating Tobacco Dependency programme. This is also highlighted in the 10-year health plan, which has a clear ambition to integrate opt-out smoking cessation interventions into all routine care within hospitals, which also includes the expansion of such services into emergency care settings and outpatient settings. Something again that Cambridgeshire and Peterborough ICB has also commenced within this financial year, allocating additional funding to support that provision. And I'm happy to take any additional questions.
And just to add to that, I think John has highlighted that it sounds as though we're coming along with all these things to do, but we have actually started a lot of the work. We've diversified our commissioning of stop smoking services. We have bespoke services for people in mental health services and the homeless and drug and alcohol services. So things have started and are progressing, and it reflects the need to change in response to our understanding of need. So, same as John, any questions first?
Brilliant. I'll take the first one. Can we change the name? Because, to be honest with you, tobacco is cigarette-based, and we know that cardiovascular disease is now more than likely going to be coming from the other aspect of the vaping aspect of it. So I think it would be more appropriate to actually put vaping in there somewhere as well.
Yes, I think we are working on the name, trying to find something that sort of is inclusive and covers all the aspects, because it's a little bit too narrow as it stands at the moment. Because vaping has certainly hadn't changed the landscape of smoking.
Thank you. Any other questions, anybody? Raj?
Yeah, thank you, and thanks for the paper, Val and Femi. For you, John, a question. Is the acute pathways from the acutes going to carry on? Because with the changes in the ICB, will that carry on? Is there reassurance that that will carry
on? That's a very good question. I'm not in a position to be able to answer that directly here today. I would absolutely endorse and hope that the support of the board that actually we can look to continue that. But there are wider implications in terms of some of the funding decisions that are still yet to be made and decided about those pathways.
My apologies. Mike?
Yes, thank you very much. Really support this work. Thank you very much for the report. Really interesting. Just by way of introduction, I used to work with the British Heart Foundation, and we used to work quite closely with Action on Smoking and Health. And what I feel you're saying, and correct me if I'm wrong, we emphasise the importance of smoking cessation services in all of this, but there's more to it. So what do we do in terms of stopping people starting? There's one question. You've already addressed inequalities, which I think is really important, but that then gets me into the issue of illicit tobacco, because if 50% of homeless people smoke tobacco, they're sure as not buying it because they haven't got the money. So it's either a criminal thing or they're getting illicit tobacco from somewhere, which circumvents the regulatory arrangements we've got around tobacco. So I think this is really important, but just getting the balance right between what the NHS does and cessation and the other areas of work we can do in terms of controlling, and whether vaping is a route to smoking or not, because vaping is undoubtedly much safer than smoking, but it's not without its dangers, and it might be a route to tobacco, well, nicotine addiction. And so if I was going to name it, I'd call it the Tobacco and Nicotine Addiction Plan. But anyway, that's just an offer.
All offers welcome, I think. It would be much appreciated. I absolutely right around intervention, and that is our first strategic ambition, and that's very much focused on young people, along with the fact that I think 90% of smokers start before the age of 18 or 19. So, and I think we do working with our trading standards, and this is where the local authority comes in terms of the trading standards aspect. There's also, we've combined some of the funding across the east of England to do quite a comprehensive campaign's not my favourite, but to do a comprehensive campaigns as well as local, because I think that's at a certain level. I think we still need to focus on those local messages and to get those messages out about vapes, because I think a lot of people still don't fully comprehend their advantages, but also the risks. And they can be very positive, but there are some negatives as well.
Are there any more questions? Sally?
Thank you. Just to offer some support, so clearly as a public health led in partnership, but a core pillar of public health work, obviously very supportive of it, but I just wanted to highlight that tobacco and nicotine dependency remains really important public health issue. So nationally we've seen great progress and locally around decreasing prevalence of smoking, but actually it even more highlights the importance of the health inequalities element. So that's not seen equally across population groups. So many more people who live in deprived communities smoke, and then that kind of compounds health inequalities throughout the life course, so it's really important. And the other element is those higher risk or higher prevalence smoking groups, like people with mental health, serious mental health illnesses. And those types of groups, I think, in years gone by in the world of tobacco and smoking cessation, it was almost kind of really hard and actually not the low-hanging fruit, so not so much focus, but that's really changed, and I think we just need to really keep pushing on those higher risk, higher impact groups and where there's health inequality. So just really supportive of the work and the ongoing partnership across the Alliance with it.
Lewis?
Thank you, Chair. Yeah, thank you very much for the report. The information is really interesting. And I take some from that information. Yes, we have driven since 2011, we've driven almost, well, at least in Cambridgeshire, half the tobacco consumption from 20 to 10%. However, if you see the table of vaping, we are picking up at 13%, so we are pretty much, we've made up the gap back up and over. I understand that at the moment we haven't got the evidence to establish how damaging vaping can be. I think there is some, but you highlighted here it contains nicotine, flavorings, and other chemicals. From a public health perspective, I think we still need to tackle this because it's an unknown, and we cannot gamble with the health, especially based again in the statistics of young people. 27% in the Finland, year 10 pupils are taking up vaping. It's regularly vaping, 5% in Cambridgeshire, 3 occasional, that's an 8% if we take that. Finland is 27%. It is staggering, and that it would be a real concern. I agree with tackling those groups that are really deprived, that are usually consuming tobacco, the homeless, the people with certain mental health. That is targeted. We can identify those probably easier. But the other concern, for me, the biggest concern is the young population. And in your report, you highlight the mass media apps, which I don't understand. That part is not detailed there in the report. And how do we commission that from the ICB, I guess? Is this, or is public health at CC at county level? Who's paying for this? And I say this because I have a 14-year-old girl. Are we doing this in the places where they actually get their information from? In other words, TikTok? Where are we doing this? Why at local level? Wouldn't it be better if this is done with resources? I don't like to centralize much, but wouldn't it be better if we actually do a campaign and a message that will get them through those media outlets that they actually consume, so we target our resources much better, and we can measure in those outlets who's watching that, who will receive it. So yes, probably more information about these apps and mass media campaigns we are running, because the information is not there, so I'm not clear whether we are actually getting to young people. Maybe, so that's a question really.
Okay. Yes, absolutely.
May I add on that?
I'm sorry.
I do apologise. Mass media, I mean, if we are paying for commissioning advertisements so we can target young people, how tangible is it? Because realistically, what I understand about algorithms, if the children or the young people are not going on to non-smoking or anything of that nature, then they won't actually see the advertisement. And are we just not wasting the money then? Thank you.
Yeah, okay. Yes, we do fund apps, and they're increasingly part of the kind of repertoire of interventions. And I think there's evidence they have some traction, but it's actually getting young people to the right apps and they get the right information. And one of the ways we do that is through school-based programs, and other services that interact with young people, so they get the information about where to go and we also pick up from that where the best places to go and where the best places to place that information, because it also changes. And I think that one of the things that we are working on with the regional program is to do exactly what you've just said, is trying to understand where best we can develop the apps, because we do use social media, but it's actually which social media is most impactful, and also mindful of the fact it's in the context now of the current kind of wider discussion around the use of social media and the use of apps. So I think that adds another dimension to it as well. So it's developing, it's part of the program, but it's actually finding the right way to do it. And it's, you could get into a discussion. I nearly went off into a discussion which is probably not appropriate for this forum.
I am going to offer a debate in just a second. Yeah. Any other questions? Mike?
Well, it was just to expand on that last point. I think if you are going to use media messaging, I would strongly urge you to find a youth group and ask them how to, yes, I'm sure you do. They're the ones who are going to know what are salient methods of interacting around these sort of issues. And the other is, am I right in thinking that the law is going to change around smoking on NHS premises in the next year or two?
Well, in theory, that shouldn't happen now, but it does.
It's voluntary at the moment.
Yeah. And one of the issues is actually how do you enforce it, because it's busy hospitals.
It's costly.
And it costs.
Yeah.
And there has been a lot of investment in smoke. All local authorities have received additional funding, but that is out of the scope at the moment. Okay. So I don't know about that change. The most recent one has been inserts in cigarette packs, which we responded to a consultation on that. Whether that will happen, I don't know, because the legislation, the whole smoke-free generations, it's still bit by bit going through Parliament.
Any other questions? Members, would you like to move to debate? No? The recommendations are set out on page 87 on the agenda pack, from A to D. Would you like to approve? Is that agreed? Agreed. Thank you. Kizzy? As we have been going for an hour and a bit, would you like a quick comfort break? Is that a yes or a no?
Keep
No?
going.
We carry on?
Yeah.
Brilliant. Thank you.
Right. Obesity, another kind of...
Can I introduce it, if that's
I'm
okay?
Sorry.
Thank you.
I didn't mean to take no role whatsoever, my apologies.
You're just taking my job,
being a
aren't
bit
you? You're just taking over. Thank you. Item 8 is the Cambridgeshire and Peterborough Obesity Charter. That's why I wanted to do it, because we are very part of it as well. This item can be found on pages 117 to 148 of the agenda pack. Val, would you like to introduce the...
Okay. I'd like to start by thanking the SRO support on this, which is yourself and Councillor Navarro and Jan Thomas, who is here, and also my sounding board, Liz Watts, who's also made helpful comments in the course of the development, as well as other people as well. But I thank you for your support on this, certainly in terms of finalising it and making suggestions. This came about, obviously it's one of the priorities for the Health and Wellbeing Board, strategic priorities. It fits into the environmental priority. And I think it has come here over the past few years, various pieces of work that we've undertaken. And the discussion at the June meeting, I presented a framework, strategic framework for refreshing and taking it forwards. And the task that came out of that would be that the local partnership boards would develop their plans around obesity, look at what's been done. And I actually think there's an awful lot of work that happens at local level at the moment. I think there are countless examples, and I did provide that some of that information in that original presentation. Come last October, we had a development session when we were going to discuss the local plans, but that changed into a broader discussion, and it probably went to one of the sort of core issues around addressing obesity, was that it really is one of those things that it demands a system-wide approach. It impacts on all services, all communities. I don't have to go over the data. I think you've probably seen lots of data on obesity, and we haven't really seen any shift in it at all. There's evidence around where systems do work together across certain areas, certain subjects, then that has an impact. And I think this is all about an obesity charter, and there's some famous ones, most notably those in the Netherlands and Milan, but there are a few others which have seen, which have gained traction on obesity rates. And out of that discussion became, well, why don't we have an obesity charter? Let's really look at this, because we're not getting to many of those wider social determinants that affect obesity, as well as support for people to adopt healthier ways of living, and support for losing weight. So out of that came the charter, which is attached, and also a delivery plan. Now the charter does go up to 1945, so the delivery plan might look rather large, but it is a rather long time frame. And following reviewing with the SROs the charter, it was agreed to focus on the priorities of children and young people, and the public sector, what they can do, the public sector can do as a start of this, as something to handle. And I think that the charter also offers a framework, because charters are about a framework for change, for collaborative change, a collaborative action. And it does the charter describes, what people would be signed up to, the governance process and so forth. And that is the ask, essentially. This charter offers a way through all the things that we've discussed today in terms of the collaborative nature of that is necessary for so many of these areas that we need to address. And it's interesting, because we talked about a system-wide charter, and yet we've also talked very much about a local approach, and I think we need both, actually. I think the elements of the charter where it needs, you're thinking more across the whole system, but you also then have to look about how that plays out at a local level. So the recommendations to the board is that to approve the obesity charter, that senior leaders socialise the charter in their organisations and comment on it. That, this is the first iteration, but ultimately we would be looking for sign-up from organisations across the system to take this forward. There's also, I think we had quite a good discussion, the SROs and myself, around what external expertise can we pull in. And this expertise would support a charter-wide delivery group that would work to monitor delivery and blocking those barriers and making sure there's progress. And also then obviously to support the proposed 2 priority areas for action. So I think there's a lot of information in the charter itself and also in the proposals for delivering it. and the priority areas within that delivery programme. So happy to take any questions.
Thank you. Well, firstly, let me thank you in regards to this charter itself. I know you've done a lot of work to it, and myself and Mr. Navarro are quite happy. Is that a fair comment to say? Obesity is a cause and also a point of causality. And what I mean by that is, unfortunately, it causes a lot of other problems within people, anxiety, mental stress, physical problems, and so on and so forth. I could go on, but most of this is in there. So, thank you for your hard work. Are there any questions from the committee? Liz.
Thank you, Chair. I'd like to thank Val for all the work that she's done on this and for the opportunity to comment on it on an early draft. And I think it's a good piece of work. I think it's really important that to make it a document that people really own, that we do quite a lot of work within and across our organisations. And from the local government perspective, I think it would be great if you could come and present to the Public Service Board as a kind of initial step to introduce this charter to local authorities. And then I'm keen to make sure that the delivery group has really good representation from across the system, and people have an opportunity to kind of input into the delivery plan, and we really kind of make it a live document. So thank you, Val, and looking forward to further work on this.
Thank you. Any other questions? Mike?
Val, another terrific read. Thank you very much. And I'm sure from a Cambridge and Peterborough Foundation Trust point of view, we'd want to support this. I haven't had an opportunity to look at it in detail, but a couple of things just struck me now, and that no doubt we can develop. The word that jumped out from the 5 priorities was the individual blame, and I think making sure that we approach this with that in mind. A couple of things triggered that thought. A number of patients who with serious mental illness are obese because of the way we treat them, and it's a side effect of their drugs. We can't blame them for that, and I think it extends to everybody. And the other is some people who are obese is genetically determined, and it's clearly difficult to manage. So I just draw out that issue around no blame, and I would, if I was doing it, I'd elevate that a little bit in the charter.
Okay,
but yes, thank you very much.
Thank you.
Mike, you made some good points. Thank you. Any other questions? Sally?
Thank you. Just in support of Liz's point around taking it to Public Services Board or and some other forum where some of the people that aren't represented from Health and Wellbeing Board in terms of senior leadership around some of our core organisations that we would want to be signed up to this are present and we can socialise it. I wonder whether, because we've had the conversations about the Anchor Institutions partnership as well, and there's a workshop on that coming up, whether we should try and sort of cross-pollinate around the key organisations that are anchor institutions and that should also then therefore be signed up to this as well. Because there may be some that aren't around this table now that would then be picked up to do that.
Thank you, Sally.
Well?
Thank you, Sally. But that was in the paper. But also Paul's allusion to was it a police charter this morning you mentioned? You mentioned a charter. And they are very, and we talked about having the synergies between charters, and otherwise we'll have, charter 1 to 20. So it's actually, so thank you, Sally. That was in the paper and I forgot to say. Thank you
very much. I would suggest that we need to take a break before recommendations, if that's okay. Sorry, I do apologise.
That's okay, thank you. I'm obviously here to represent the voluntary sector, and I just would be lovely to see us being able to endorse this through signatories, because I noticed that the voluntary sector isn't represented on there.
It is, perhaps.
There's a space to add other signatories, aren't there?
On the signatories, yes.
Yeah. Because there's some really good work going on with the volunteers. If you think about Living Sport, for example, they may be able to sign up to this and represent the voluntary sector fully. So similar to what was suggested earlier, perhaps this could be brought to the voluntary sector network, because there's over 100 members there. So if this could be brought there, I think there'd be a lot of support for it.
I think there are some good examples of the work that the voluntary sector does in communities.
Yeah. Yeah, I noticed you've talked about care homes as well, and I'm thinking of, from an Age UK perspective, day centres, etc. It's of great interest. Thank you.
Thank you. Sorry, my apologies, Louis.
Thank you, Chair. Thank you very much, Paul. It's a great piece of work. Sally, just a question there. Which organizations do you have in mind that should be coming along, that are anchoring as well?
So I didn't have any specific in mind, but there's a wider conversation about the anchor institutions and who else we might want to incorporate in that, and we could join up the conversation. So the university, for example, is one that just sprung to mind then, and whether there's any others that we might want to pick up. CUH aren't here today, but obviously would normally be. So yeah, it's just whether there's anyone else that we would, as system leaders, that we would want to try and pull into the conversation. I don't know about if there was anything else in your mind on that.
Yeah, no, I welcome the report and also the recommendations. Make obesity obesity prevention a strategic priority is a must. It's very important, and make it community-led. That is also imperative, and this fits perfectly with the intention that we're trying to do. We have very good examples. For example, in South Cambridgeshire District Council, they have good teams doing good groundwork, and I'm speaking to them, I'm liaising to them, and the plans are hopefully, involving them. You have a good team working there, Liz. Yes, the rates of obesity are not declining, and in places, as you mentioned, such as the Netherlands, where they saw an initial progress, it has plateaued, and that is because this is, and you explained it very well, is so complex a problem. It will need a very complex approach as well, and it's systemic, and we have to make it a priority, and we have to come up with imaginative solutions to solve it. Thank you.
I think one of the things which I didn't mention, woken it up, thank you. I think one of the things I hadn't mentioned is the word movement, and this was something Jan was very keen on. I think Councillor Bauer, you've mentioned as well, that it needs a movement, it needs a cultural shift in how we look at it as well. And I think that will take a while as well. I think there are so many aspects to this and its complexity again, but I do want to mention that because I know Jan was very keen that we should see it as a movement.
And it's great to hear that the ICB and Jan I know that she is very, very keen. And yes, you mentioned the movement there in point 2.3. It is a movement, but every movement has a starting point, and we have to spearhead that somewhere, and that is possible.
Are there any other questions? Brilliant, thank you. We will have to go to a break. 5 minutes. At the moment, we can't go to recommendations because we're not Cora, unfortunately, because Pam left. So a 5-minute break, please. Thank you. Hi there, everybody. Thank you for your patience. Unfortunately, due to not being Cora, we will now suspend the rest of the meeting. And what we will do is we will set up another meeting on a future date to listen to recommendations and the remainder of the agenda. Is that okay? Thank you. I will close the meeting now. Thank you, everybody.